Care Lab.
Welcome to Care Lab. Yay, it's Care Lab Day.
We're so excited to be together. And guess what? We have an all OT Care Lab episode today.
Oof, can I say, I probably shouldn't say this because we have a lot of really wonderful guests, but I love all OT episodes because we can just soapbox.
We could just soapbox and nerd out.
the whole time. So we do have a really, really wonderful guest with us today. I am a little bit biased because this person is not only has been an OT for 45 years with a rehab focus. She has a PhD in neuroscience. She's been a professor of occupational therapy for 20 plus years, which is where I come in because she was actually one of my professors and someone that I consider to be a very important mentor in my life in many ways. She's also had a couple of knee replacements, a couple of back surgeries, an Achilles repair, a bunch of stuff. So she's been through it all. She knows a lot of stuff. Welcome, Dr. Marcia Neville.
Thanks for coming on.
Well, thank you for having me.
Absolutely. Okay, so we're going to start with an icebreaker, which I just started, but I realized I don't have the icebreaker. Brandy, it's you.
I had the icebreaker. It's not too hard. This is
Okay.
This is a softball for you, okay? All right, so it is the end of the year, and everybody usually has some kind of tradition, small or big, that they like to do in December. Tell us what your traditions are. What's your favorite thing to do in December? You got to start, Marcia.
Oh, yeah, you go first.
I forgot to tell you that, like, you're on the hot seat first. Boom, go.
Oh, December traditions. Wow. Well, first of all, I must say I am a procrastinator when it comes to Christmas gifts. So I don't do a whole lot of Christmas shopping until very late in December. And the first part of December, I just sit there and think about what should I be getting people.
And this is your favorite thing in December?
Ruminating, procrastinating,
just
and
ruminating and procrastinating. Yes.
Yes, ruminating and procrastinating. And of course, then putting up the Christmas tree the day before.
That's funny.
The other thing is, because I have been in academia for so many years, there is that rhythm of the academic year. So, it's final exams, it's crying students, it's closing out the end of the year. It's not a good time.
And it's a reason for the procrastination. You got stressed out students to deal with.
Yes.
So what you're saying is that the holidays can be a stressful time for lots of people for a variety of reasons. And sometimes that makes them not always the most enjoyable.
Mm-hmm.
That's fair.
Yeah. But I always love when finally school's out and the holiday actually begins and the family's all together. And we have a pretty goofy family. So we have traditions of all the kids get peanut M&Ms, despite the fact that they're now 40 plus years old.
That's cool. That's why traditions are awesome, because
Yes.
they carry on. That's the point. They carry on.
Mm-hmm.
Yeah.
Okay, it was my icebreaker. So, Amelia,
I know.
favorite December activities?
Ooh, there are a lot of things that I really love. So the Dallas Zoo every year does like a big, huge Christmas display. And by a big, huge Christmas display, I mean the entire zoo is literally decorated with like hundreds of thousands of Christmas lights. And it is so cool. And they have places where you can go get hot chocolate and you can make s'mores. And it's really, really magical. And that's one of my, I'm same as you, Brandy. It's hard to always pick a favorite, but that's one of my things that I really love to do with my family and my kids, and everyone's excited for, and especially if it's actually cold here in Dallas for us. So, it's kind of like crisp in the air. That's absolutely one of my favorite things to do in December. Okay. What about you?
Okay, so I have a young family, so we're always kind of trying to create the traditions that are going to last until their 40s.
Mm-hmm.
And so, the one, we have lots of things I like, and I don't like to pick favorites, but one thing that I really love is that we take our family pictures. Amelia, you were talking about this earlier about
Mm-hmm.
Christmas cards. We actually do it on Christmas Eve, and we send out New Year's cards. And so we take the time on Christmas Eve to go take pictures at the same place every year. And we do a little staycation at this hotel because we use their lobby for our pictures.
Okay, so first of all, I think that's really cute and very fun. But I have a question for you. How do you turn that card around in time to actually get it out for New Year's?
So Christmas is one day, but celebrating New Year's is all of January.
Okay, that's fair.
So it is not necessary. I don't feel the stress that I have to like get it there before it turns January the 1st. As long as it gets there
Gotcha.
in January, I'm fine with it.
That's fair. I also like that it kind of spreads out the work of the holidays a little bit because I think like for me getting Christmas cards out it's actually one of the things that I really really enjoy and I love getting Christmas cards, but it is probably the most stressful thing about the holidays is like making sure that I get the card and the letter and all of that stuff kind of written it out on time. So I like that idea of spreading
Spreading it out.
spreading that out a little bit.
Mm-hmm.
Okay, well, that was all wonderful. We should probably, though, talk about one of the things that Dr. Neville is an expert on, though, what we've got her on here today, which is to talk about discharge planning, which has been a kind of a hot topic here on Care Lab in the past. One of our most popular episodes, actually, Brandy, was when you and I were talking about discharge planning. And I think that, well, I know that Dr. Neville has some really incredible insight to offer into this as well. So take it away. No pressure.
Well, I am so glad to be here to talk about a topic that I really am so passionate about. Um, and this came about as primarily because we all know that hospital stays have been shortened.
Mm-hmm.
And particularly in my area of expertise and interest is rehabilitation. So these are people who probably oftentimes entered the hospital and are going home in an altered physical and cognitive state. Um, and this can be as simple as hip replacements, knee replacements, or it could be as serious as somebody who's had a stroke or a brain injury. And these people go from the hospital to rehabilitation, and the expectation is they may stay 2 weeks and then they're going to discharge home. Now, these are people who went into the hospital. It could be for an elective surgery, or it could have been under an emergency, such as a stroke or something. But they're going home and they're not going to be the same oftentimes as they were prior to their admission to the hospital. But then again, we as therapists all know when you interview them and you say, well, do you have any problems getting into your house? Well, no, that's no big deal.
Mm-hmm.
Or, you know, how do you prepare your meals? Oh, I don't have any problems with that. And the issue becomes that they're remembering where they were prior to admission.
Mm-hmm.
And these weren't problems, but the recognition and the admission that maybe things are changed and different is what poses the problem. And so, as we talk about planning, and I'm a true believer in discharge planning starts at admission.
Yep.
When that person comes to me and I see them in the hospital, the first thing I'm thinking about is what is their going home environment?
Mm-hmm.
And will
Mm-hmm.
that going home environment afford them the quality of life and independence that they want, deserve, and need? Um, and so, in saying all of this, the evidence certainly shows that readmission rates um, go up um, quite rapidly for people because of falls post discharge, medication errors post discharge. And let me talk a little bit about that. And please pipe in as you hear me speak. One of the issues with medication management is the person may have been managing their medication prior to admission, but
Mm-hmm.
now medications have changed. Maybe the dosage has changed, the pills have changed. And is this client prepared to manage their medication now? So, what we know causes readmissions post discharge are, first of all, they've been discharged to the wrong environment,
Mm-hmm.
and that discharge fails. They have a medication error and have to readmit to the hospital, or they've had a fall. The other thing is a isolation issue that happens after discharge for people that don't have access to mobility in the community. And so, that being said, do you guys have anything to add to it or
Yeah. So,
this?
oh, sorry, Brandy's got questions. I'm gonna let Brandy go.
I got a question. So
Yes.
how would we know that they got discharged to the wrong environment? Like that's the reason. Like how is it like from the data and the research like that you're citing that I know is in your head?
Mhm.
Explain that a little bit more.
That's a really good question. So, what they determine as discharge to the wrong situation is the person gets readmitted and has to discharge. Let's say the person went home to independent living
Mm-hmm.
and it was not working. They weren't
Mm-hmm.
able to take care of themselves. They were maybe even um, the family members deem that this is not the appropriate discharge environment because the person, first of all, they don't have the support system in place with caregivers or whatever is needed to then sustain them in their home independently. And we all know the stubborn parents that we've had who said, I'm not going to assisted living.
Mm-hmm.
I can
Take
do,
me out of this house feet first.
yeah,
Mm-hmm.
I can take care of myself. Well, that person ends up either getting readmitted to the hospital or the family is now looking for a higher level of care
And
that
so
they're
the data
having.
is letting us track them all the way through. Like they
Right,
discharged to here, they came back, and then we discharged them to this other place.
right.
Got it.
Yeah.
Okay.
Okay, so then I have a follow up question for that then. And we can just kind of think, I think, take these things one thing at a time. So, thinking about discharge environment. So, there are multiple people involved in this discharge planning decision, right? There's
Mm-hmm.
Right.
the
Mm-hmm.
patient themselves, there's the family members or support system of that person, and then there's also the healthcare providers and the healthcare team that are involved.
Right.
So, what are the different things that each one of those players can do to help make it so we're not getting discharged into the wrong environments?
And
You
before
know,
you add to that, I think we should add one more piece, and that the insurance and the payment source is also being considered when it
Mm,
has to go through the discharge planner. So,
that's a
like,
great point.
yes.
yes.
Yeah, it is multifaceted. And this is where I really feel like the care partners have to be part of this discharge planning team. And we have to be very honest with the care partners, and they have to be honest with us about what level of care they're actually planning. You know, the daughter, the wife, the son, the father says, "Oh no, I'll do all the grocery shopping, I'll do the meal prep." But then when we look at it, this person's working full time and doing this on top of it. So it's like, is this sustainable for the period of time? And then, so part of it is a real honest discussion with care partners. And as we as therapists evaluate the client and say, well, they're going to need somebody in there for half a day, 4 hours a day, or something like that for self care, maybe for meal prep. Um, and also, if we deem that this person's going to be socially isolated, and this oftentimes happens when the person returns to their independent living home. Now, if they're in a retirement community where they have access to other social events and stuff, that can really play into their cognitive um, stimulation and socialization that they need to sustain their cognitive functioning. But if they're going home and isolating in their own home, then we have to educate the care partners that they have to have some level of socialization. That's critical in particularly the aging process. But we all want socialization. We all need people in our lives.
Mhm.
Can I chime in and add something here, which
Yes.
is that in all of my years of practice, in all of the settings that I've practiced in, never ever has a discharge like a discharge template or a discharge program ever included socialization as a factor in the discharge plan. It just
Mhm.
hasn't. It's not part of how we do things in our healthcare system. But what
Yep.
you're saying is that that part is actually key to safe discharges. Can you talk more about that?
Yeah. The We know that social isolation is detrimental to our cognitive functioning. And as we age, it becomes more important, but it's important across the lifespan. And so when people get into situations where they're they're not having access to socialization and people contact, then they're not getting the cognitive stimulation that they need to sustain mental functions. And that's where we'll see a decline in people's desire for independence um, and living in a productive way. But you talk about that, and one of the things that I can mention is that in all of my passion for discharge planning, I developed the Discharge Planning Assessment Tool, and it has multiple areas of it's basically a checklist across all these different areas of care partner commitment to caring, the environment and how accessible the environment's going to be, and it's basically a yes no. Is this a problem or isn't it? If it's a problem,
Mhm.
then we need to address it. If it's not a problem, great. If the person never cooked a meal in their life and they have somebody who's going to continue to cook their meals, it's not a problem.
Right.
Um, but and it does include things like access to socialization and access to community, access to prior interest areas, going to church if you have a faith base. All of those things are really critical for a successful discharge.
Hey there, it's Amelia. Listen, I am so thrilled to have a great resource like Ask Sammy as part of the Care Lab team. And here's why. It's a game changer for aging in place because it makes it so simple. All you do is ask. Just type in your question or even tell Sammy what the problem is and get tailored solutions. Everything from innovative adaptive equipment to comprehensive resources. It's a great way to become more empowered, to live more independently, and to live with greater confidence. And my favorite thing about how Ask Sammy works is it's deeply rooted in dignity and practicality. So, whether you're a fellow therapist, a care partner, or someone who's seeking solutions for themselves, visit www.asksammy.com. We're going to link it in the show notes so you can find it there. Start making home more accessible today. Now, back to the show.
So in your discharge planning assessment, who who's the target person to complete it?
The occupational therapist. I really
And
believe that we as OTs, with our level of intimacy that we have with our clients, affords us the opportunity. Now, it's not done in isolation from nursing because there's certainly questions there about medication management, side effects of medication, that I feel very strongly that our nursing community needs to reinforce. Um, we've all had the experience of working and being in the client's room when the nurse comes in with the pills for the day or whatever, and they said, "Oh, here's your pills," and they hand them that little white cup of water, and they pop the pill, and down it goes. And I am a strong advocate that when um, it's up to the client to start being trained in the hospital on their medications.
Yep.
And so the client should be responsible for, and we can put it up on their whiteboards or things like that as to what time their meds are due so that we get them started and start educating them, but that they ask for their medications and they ask specifically for what pills they need. And that also we educate them on what these pills are doing, why they're needing to take them, and um, any side effects that those pills might have that they should be looking for. And that should start at the hospital level. So I always advocate for when I'm working with a client and the nurse comes in and gives the pills, I'll say, let's talk about what these pills are.
Mm-hmm.
It doesn't do the whole thing of getting the client responsible for the scheduling of it. But if that's something they're going to be expected to do when they're discharged, then they should be doing it in the hospital.
I think that's like such a fair and important point, but it feels like there's so many barriers to making that actually happen. Like there's such regulation, rightfully, about like you can't even bring your own Tylenol into the hospital. You're not supposed
Right.
to take it, right? Because they need to know exactly everything that's going in, and places are over understaffed, and they get around when they can get around, and so like have you seen any best practices or great examples of places where this has occurred, or even small programs where maybe somebody's in like a discharge apartment style setup and then we've done it through there? Like, do you have any like actionable recommendations for like the OTs that are listening?
Yeah, and there's a lot written in the OT literature about medication management. So where I kind of expect nursing is to help me understand what these meds are, what the drug interactions are, but the daily activity, and medication management is a daily activity, becomes
Mm-hmm.
the OT. So I, as the OT, then can start figuring out strategies for this person to understand. Maybe it's a med pack that they have in their home and we have it pre measured, pre prescribed. Maybe it's setting up a schedule. And again, this might work with the client and the care partners. What is going to work in their home so that this person knows when they're supposed to take their meds and what meds they're taking at that time? So it's really kind of falls to the OT when it becomes the daily activity of taking the meds.
And even like expanding that into the hospital setting, I think, because you're right, there are so many barriers in a hospital setting, Brandy, because of different regulations and things like that. But patients even getting more information about what their med schedule is, having that written down for them in the room, so that at the
Mhm.
very least, even if they can't control it, they know what it is, when it's coming, and why it's
Mm-hmm.
coming, so that they can, one, get in the habit of knowing those things, but also
Mhm.
be able to advocate for themselves better in terms of their own medication management in the hospital. Because just because the person doesn't have their meds to dole out to themselves doesn't mean that you're powerless over your medications in the hospital. At the end of the day, the it's the patient who ultimately decides what care they do or do not receive, right? So
Yeah.
empowering people with that information, I think, is something that we can all do, and that, to Dr. Neville's point, is something that falls on the OT's shoulders to really help with in thinking about the now, but also that transition home.
Mhm.
So, on the discharge tool, is the goal that it gets done when they first get admitted, and then also done again when they before they leave, and then use that as measurable data to show outcomes of what you've been working on?
That,
And so, yeah, tell us how you would like to see it play
that's
out.
exactly it. And again, as I said before, discharge planning starts at admissions. So when I'm first working with this client, I'm getting all the care partner information. And I'm working with those care partners because oftentimes they have to get things in place.
Mm-hmm.
Um, they may be taking some leave in order to help out, or um, things like that. And we could talk about whether this is going to be a permanent condition, such as a stroke or a brain injury, or um, things like that, or is this simply a temporary, like a knee replacement or back surgeries, or but so you're starting early on, talking to the family members and letting them know how much they're part of this team if they're going to be a care partner in this process. And then it's as we do our daily activities with the client, when we're working on accessing for self-care, is going through the list of things about the bathrooms, about the kitchens, about the bedroom area, and completing it as we go. It's not something where you just sit down and formally go, okay, is this a problem? Is this a problem? It's when we're doing the shower and we've got this beautiful setup in the hospital with the tub bench and the this and the that. This may not be the client's home. We all know. And so it's really talking to the client about, so tell me at home, what is your setup?
Mhm.
And we, of course, because of our expertise, can ascertain whether we are thinking there's going to be a problem with access, that maybe things need to change, or maybe the equipment that they have or at home now isn't going to work, or maybe they need new equipment or different equipment. So it's that kind of process. Now, as we go through, as I said, it's a yes, no, or not applicable at all. So if we deem things as a problem, and that's how it's addressed, will this be a problem? Then if we say yes, we continue to go back to that. And at discharge, then we hope to resolve a lot of those yeses to say, no, we've resolved that problem. It's not going to be a problem at discharge. But yes, then the hope is that this becomes predictive of a successful discharge. Because what we don't want is an unsuccessful discharge. And the other thing that they've shown in the literature is unsuccessful discharges leads to depression
Mm.
Mm.
and anxiety, and we don't want that to happen for our clients.
So we've hit on three things here that are really important for discharge. One is making sure that we're planning for the environment that someone has and making modifications as need to be made before someone goes home.
Mhm.
Making sure that someone has the appropriate social support, both in terms of actual hands-on or like supervisory care that might need to be provided for that person, but also for like socialization that has to do with leisure and just being around other people and quality of life, because that impacts cognition and function as well. And then the third thing was medication management being super, super important to ensure a safe discharge.
Mhm.
Are there other things that the discharge uh,
Living.
tool covers?
I'm thinking really hard. Oh, sleep,
Mm,
sleep hygiene. And so, the whole sleep routine that's so interrupted with hospital stays, and
Mm.
then
Yes.
changes in medication. And so the whole idea of sleep hygiene and exercise.
okay, talk a little bit more about that sleep hygiene and exercise. Like how do those things go together?
Yeah, because if we exercise, we have better sleep hygiene. So I could talk forever, and this will be another podcast that we'll talk about with exercise, cognition, and our brain body connection. But as we exercise, and I don't mean exercise in going to the gym, or you can get, actually, what the literature says is exercise should be mixed with a cognitive press. So
Mm.
I think one of the funniest studies I ever read was where they had a group of people who just did. an aerobic class. And then they had another group that didn't do anything but daily activity. And then they had another group that participated in a dance class. And of course, the dance class did the best. And the summation is that as we exercise and we have a cognitive press with it, the stimulation that we're getting with our blood flow and our heart rate and all that great stuff that happens with endorphins when we exercise then is mixed with things like um, um, a release of neurotransmitters in our brain that because of the cognitive press of following directions and doing this and doing that. But we all know when we're also doing exercise and doing something like a dance class or something, we're also getting
Socialization.
Socialization, yep.
And it's
The
fun.
trifecta. And it's fun. Yeah.
Yeah. Yeah. Rather than sitting on an elliptical bike going, ning, 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 you know? So that whole combination. So as we discharge the client home, these are things that we need to take into consideration. Is there is the brain body connection. And when the body has had something happen to it and our mobility's changed, and of course we have emotional feelings about all of this, that we have to think about that need for exercise, not for the sake of, well, it is for also the sake of gaining more mobility, but it's also for working on our brains so that we can have more initiation, more motivation, more initiative to then follow through on some of the exercises or the things that the PT is going to make us do in order to get better, or somebody else is going to make us do to get better. Does that make sense?
100%.
Totally.
Yeah.
Yeah. So it does go into that. And does the person have access to their therapies? Do they have access to the um, the things that they're going to need to continue with their rehab process? But then also, again, as therapists, while the person's in the hospital, we need to be looking at, okay, what is your home environment for doing exercise? If we tell the person
Yeah.
they need to walk so much, do they have access? And we might need to help them map out within their house, or maybe getting outside and how they can walk safely in their community. So we need to reinforce the home exercise program in the hospital and have them initiating, okay, this is my time schedule, this is when I'm going to do my exercises.
And also sounds like, not necessarily giving them a form type of home exercise program. If we're talking about all these things, then
Mhm.
we should eventually come to a plan that says, like, I'm going to go to swim class every Thursday, and I'm going to do walking around my neighborhood on Mondays, and I'm going to do walking around my kitchen island for the first 2 weeks, or whatever that plan is. But
Yes.
it should not necessarily, not that the exercises that are wrote are bad, but that it could be much more enhanced if it has a cognitive action with it, it has socialization with it, and if you can like make it fun.
Hmm. Yeah, and that's why I'm a real strong proponent of things like Tai Chi, because Tai Chi brings in that whole visualization. Now, you don't have to be trained in Tai Chi, but you can do that with your client as they're doing their arm motion exercises, or they're doing their leg
Mm-hmm.
exercises. Is you can come up with some mantras of, you know, I can run fast, I can run fast, I can run faster, or I have power, I have power, I have control. There's lots of things, and the evidence is really, really strong in these areas for um, how this can build not only our body strength, but our brain strength.
Yeah, connected.
And if I
Before
could
we get
plug
out of
another podcast, Dr.
yes,
Suzuki, who's a neuroscientist, has some wonderful podcasts on brain body health.
Awesome.
Yeah.
yeah.
Hmm.
okay, I really want to change the topic a small bit because you didn't have to tell us this, but you did in your bio about all the ways you have been a patient. And
Mm-hmm.
so I am assuming because you've been OT for 45 years, those things happened after you were a clinician, after you're an OT. And so I'd love to hear your experiences, especially about getting MRSA and PEs and those kinds of things that happen in the hospital that we know how we're supposed to try to prevent, and
Right.
like just from the flip side of it, as a person in the hospital bed instead of helping them, like what, I guess a specific question would be like, what problems did you see that occurred in your care, and what solutions did you either see in action or now know are good solutions because you've experienced it from both angles?
I think one of the things, and I guess we've talked about the medication management. I went home on medications, as I'm leaving the hospital, literally as I'm leaving the hospital, they're handing me prescriptions for things I'm supposed to start taking when I get home.
Mm-hmm. Care Lab listeners, it's Brandy, and is the founder of a platform made to make aging in place easier for everyone. I knew it would be incomplete if we did not have education, especially for caregivers. So, whether you're a family caregiver or somebody who trains a whole organization, Higher Standards caregiver training videos are for you. I'm so proud that we were able to partner together with Amelia in order to provide these to you because they're easy for everybody. You get great occupational therapist led training on topics like transfers and how to care for someone as they age, or maybe as things change when you have Parkinson's. So, no matter if you're the loved one who doesn't know exactly what to do next because things are getting different, or if you're a professional who trains caregivers that go into the community and you need some quality education, you get both from Higher Standards Caregiver Training. And you need to check them out at higherstandardscaregivertraining.com.
And and first of all, I was stressed going home. I live alone. I had, periodic care partners that helped out, but it was really, it was, there was in one of the incidences I had where I started reading my discharge papers about 3 days after discharge to realize how many things I had done wrong.
Uh-huh.
And can I just I would just want to butt in here and say, and
Yeah.
you've been an occupational therapist for decades. You have taught for decades, and you're a neuroscientist, and you are struggling with this. So, if you of all people are struggling with this, how messed up is it for folks who don't have any of that background or experience?
Right.
That's why I have, and as I went through each one of my procedures, I became more and more cognizant of where the deficits were in our discharge planning.
Mm-hmm.
Um, and so that's one of the big ones. The other things is I did have complications, and thank God I, as a therapist, knew things weren't going right. So when I
Mm.
got the MRSA, which was after my first back surgery, then I went in and I had all the nasty signs of MRSA, including the fever, and they gave me the PA, and the PA said, "Oh well, yeah, it looks like you might have an infection here. Let me put you on an antibiotic." And I said, "No, I think it's more than an infection. I'm vomiting, and I was dry heaving, and I have a fever." And she was pretty insistent, and I said, "I need to talk to my surgeon now." "Well, he's in surgery." "That's okay. I'm going to wait." And I waited, and he came out of surgery, and he looked at it. And he says, "Have you eaten today? Because we've got to go back in and open you up."
Mm.
But I had to be a very, very strong advocate in that case.
Mm-hmm.
And then I did. I had a PICC line for 6 months. I got C. diff 3 times. Um, it was not a pleasant experience that people have to go through with these kinds of things. Um, so, and then I got the pulmonary embolisms, and that I was discharged home after my second back surgery because the first one actually failed. And a few years later, I had to go back in and have a 3-level fusion done. And it was a 3-hour surgery on the table with a posterior lateral fusion. And I was home maybe 3 days from the hospital, and my spirometer was going down. And I
Which
called.
no one would know
You were
that
actually
was a
doing.
problem.
Yes, I was
Because
actually.
you were actually doing
You were
it, so then
actually-
you noticed it was going down.
Yeah, which, by the way, that's not supposed to happen, folks. If you're using a spirometer and it starts to go down, that's the opposite.
And for
And back
people,
that up, a spirometer is the thing you breathe into that they
Oh,
drop
actually,
on your
hold
table.
on. I have one. I can, let me
You
go.
have one, show
I have
the
one to
people.
show. Yeah, give me just a second.
yes, yes, I was doing my spirometer, and it went down, and I called my doctor, and he said, "Get to the hospital right now." And sure enough, it was pulmonary embolisms, and I had to go on Coumadin, and then be discharged on Coumadin, and again, all of these things are, um, we have the benefit of understanding what's happening, but could I have been better prepared?
To know to look for those things.
That could very well be the case. And of course, a lot of times those are in your discharge things.
Mm-hmm.
But again, it took me 3 days to read one of my discharge, and I think that was after my knee replacements, that I finally read what it said.
Okay, so make sure you describe it well for the people who are listening.
Okay, so the spirometer is a thing that you use to exercise your lungs, exercise your diaphragm, which is the muscle that controls your breathing, especially after a surgery. And it's really important because it helps you to be able to breathe deeply, cough, clear out your lungs. It prevents like pneumonia and other things like that. So it's important exercise to do. So what you do is you put one on your mouth, and then you suck in. You don't actually blow out. You suck in. Hold on.
Sounds like you need a couple of tries.
Apparently I should be doing this more on my own. But basically, it's showing you the volume of air that you are bringing into your lungs. So we want that to go up over time as you get stronger, not down over time. That would be an indication that you are not, that your lungs are not getting better. Anyway, spirometers.
Yeah. So, and again, we talk about the spirometer as being something that they give you for discharge. But again, if this person's being seen by an occupational therapist, that again is a daily activity.
Totally. I've written many goals for using your spirometer.
Yeah. Yeah.
Yep.
So these are some of my own experiences. The other thing, of course, and I have consulted with a number of clients. In fact, I have a client right now I'm working with. Their father had a mild stroke. He's 96 years old. And the stroke affected his swallowing and his speech, and has the facial weakness. A little bit of a dragging his right foot, but not sure that he wasn't doing that beforehand. He lives in an independent living community. There is no support in this community. It is truly independent living. He is a very social human being. And the family is realizing that he can't do his modified diet meal prep. The place that he eats at does not accommodate that kind of food prep. And that's really kind of his biggest problem right now, is he needs a modified soft diet, mostly like pureed. If we think of things like mashed potatoes or sweet potatoes, or and there's so many things you can just put in a bullet or a blender that will. Chicken pot pies do great for puree diets and stuff like that, but there's nobody there to do that for them. So the family is very concerned about what they're going to do. And of course, you can get home health in. You could possibly have an aide. Is there an agency that will do this kind of thing? So we're working on accessing what's available. The thing they're trying to avoid is transferring him to an assisted living facility
Mm-hmm.
where that help would be available. But we also have to be sensitive to the fact that the man is 96 years old and he has a social group where he lives.
Mm-hmm.
Yeah.
He does not have family or that could come in on a daily basis and prep meals for him. Actually, his house is not set up. His apartment is not set up. It doesn't have anything but a coffee pot and a sink. So
Because he goes down for all his meals normally.
yes,
Yeah.
yeah. Where a lot of our independent living will have a kitchen or
Kitchenette or
a
something.
kitchenette,
Mm-hmm. Mm-hmm.
and this has no access for things like storing food in a refrigerator or and the family's concerned because he wants to go down and eat with his friends.
Yeah.
Yeah.
So we're working out what we can do with planning all of that. And again, these things need to be put into place before he goes home. And
I
he
was
has
just
one
about to
more
say,
week.
like, he has one more week that he's in the rehab.
Yes, he's got one more week in rehab.
Okay, so you guys are working in advance. In my mind, he was at home struggling already.
Oh, no, no, no. He has not gone home yet, but we've chalked it off that we're not looking at assisted living for him, that
Mm-hmm.
there has to be some solutions. And we're talking about prep in advance and him, but again, he doesn't have access to warming his food. The kitchen will not work with them, which is kind of unfortunate.
Yeah.
So
What's up with that?
I don't know.
Like, that's all. I don't have anything out of this end. Like, what's up with that? You've got
Yeah.
someone who's probably paying good money to live in your building. They want to stay in your building. They want to come down and eat with their friends. You can't pop some stuff in a
In a
blender?
blender? Yeah.
Yeah.
What's up with that?
Yeah. Or you can't warm up stuff.
Yeah.
Or he could have a refrigerator with some prepped foods that he could then access.
See, this is one of those examples. There are solutions to these problems. There are
Mm-hmm.
easy solutions to these problems. We have to be willing to be flexible enough to implement solutions for people.
Yep.
Yes.
Because at that point, it's not this gentleman's problem that he can't get these things done. It's not him that's the problem. It's the environment not being supportive of his
Supportive
needs
of him.
that becomes the problem. And I don't know what to say except like we have to be willing to make changes to find solutions to make things better, or else what are we doing, people? Come on.
Yes. Yes.
Exactly.
And that's why I
Exactly.
say it has to start at admission. Now, our hope is, and things are looking up with his speech therapy, that he is getting stronger. He's handling food much, much better. That
Mm-hmm.
maybe there's enough of a modified diet that he could um, be sustained in between when family can be there and things like that. So we're kind of that's one of the things we're really kind of on a wait and see kind of basis. Besides lining up things like he does need more help in the home and he
Yeah.
needs somebody to help with some of the self care for safety. Um, and so working out that whole process. Another case that I'd love to talk about is a client that I saw, and this was post discharge.
Mm.
And she had, in fact, I don't even remember why she was in the hospital. But I was contacted by the family that said, could you come and help us? Mom is not doing well. Well, this is a woman, again, lived in a retirement community and was discharged home. She's widowed and she still chooses to sleep on the far side of the bed because that's where she always slept.
Oh, I would too. I don't think I could ever move to the middle of the bed. Like that's just, it would feel
Yeah.
so wrong.
Yeah.
Yeah. Well, she happened to have a very small room, and to get to the far side of the bed where she liked to sleep,
Mm.
we had to move a stool We had to move a quilt stand because I don't know how she was managing it before she went into the hospital and came home, but this was a fall waiting to happen. So
Mhm.
we went in and said, okay, she's going to sleep on that far side of the bed, which is, when she gets up in the middle of the night, she has to get around all this furniture to then get to the bathroom. Not to mention that she weighed herself every morning her entire married life so that she never changed a pound. And do you know where the scale sat? In the
Under the
middle,
bed?
in the middle of the bathroom floor.
So just the right place to trip over. I mean, I guess the good thing is if it's been there for however many decades, just automatically she's used to stepping over it, so she knows it's there.
Yes, and there were just a number of things. Her floor in her shower was not a safe floor. There were so many things that needed to be modified. Whether these would have totally been caught while she was in the hospital, it's hard to say.
Yeah.
But some of it definitely. And one of her biggest issues, and I witnessed this, and it was the most um, sad thing I think I've witnessed is the daughter was her care partner, and she was very conscientious and things, and so she was working on her mother's meds. Well, there was some change in the meds. It was not. It was not. It was the dosage of the meds that changed, not the med itself, which is another thing that oftentimes happens. And people have their old meds at home and the doses changed and there's lots of confusion. Well, the daughter, they discharged her with those foil packs of pills.
Oh, yes.
Yeah. So the daughter took the foil packs and undid them all and put them in her pill bottle.
Uh-huh.
And the nurse came in, the home health nurse, and I have never heard somebody be so disrespectful to a patient's family with chastising her for altering the med packs and it was like maybe that was an important thing to deal with, but if that was true, then could you say it a different way? But then again, what difference did it make if the pills were in a pill pack or they were in the
Those pill
pill
packs are
bottle?
so hard to open. They're so
Yes.
hard to get the pills out of.
And the client was used to having it in her pill bottle. So it was just a very sad situation. She also did things like in her kitchen, there was not, and she did some meal prep and things. She made her own breakfast. And so there was lots of things that needed to change in her kitchen to make it accessible for her.
Mhm.
Um,
I think I want to draw out the part that I think in both of these situations, a family caregiver reached out to you because they needed more direct help. And I
yes.
think like the lesson of this is like while we would like for our healthcare system to work a certain way, it just doesn't
Mm-hmm.
at this point, and doesn't mean we shouldn't try to work to change it. But for all the people who are dealing with life right now, like you have to be an advocate. That's just like the bottom line. You have to try
Mhm.
to find the resources that you need, get the help, wave the red flag, and say, "I need some help. Who can help me?" And even if you're talking to the wrong person, likely they can help get you to the right person, like you, Dr. Neville, so that you can get like specific and directed change at home so that we can make this thing work.
Right.
And I think that's like one of our greatest missions here on Care Lab is to help empower people with knowledge and information and resources so that you can be a more effective advocate for yourself and for whoever you're caring for when you need to be. Because guess what? It's like impossible to know everything, especially if you're not
Yeah.
already immersed in this healthcare world. I mean, we just heard a story today from one of the most experienced, intelligent people you will ever meet that they had a really hard time with their own healthcare, right? Getting those needs met. So Our goal here is to share as much information and experience and resources as we can to help make it easier for y'all.
Okay, so we have a mix of people who are listening to the podcast, and for all of the occupational therapists and clinicians, one, how can anybody reach out to you? And two, how can people access the assessment?
You can reach out to me at my email, which is M as in Marcia, Neville, Neville, 716 at gmail.com. Also, you can access the Discharge Planning Assessment Tool known as the DPAT if you go to Texas Women's University .edu, so twu.edu, and in the search window type in DPAT, and it should take you to the page where it describes the tool and you can download it. It will ask you for information because I am collecting. I want to keep track of who's using it and what your background is. So if you'll please fill that out, and then it will allow you to download the discharge tool.
Awesome.
Awesome. Thanks so much. So, if that's something that's valuable to you and you made it all the way to the end of this episode, then please make sure that you are subscribing, liking the episode. Leave us a comment if there's something that you want to hear about, a question that you have, something that you want to say. And please leave us a review, because that is absolutely one of the best ways to help get more people to know that Care Lab is out there so that they can hear the resources that we're trying to share with you too. So thank you so much, Dr. Neville, for being here on Care Lab. We definitely are going to have you back again, because I think there are a crazy number of things that we can talk about, and you have more stories about all this stuff than anyone I know, and they're all so great. So thank you so much for being here. We really appreciate it.
Thank you for having me. I thoroughly enjoyed myself and thoroughly enjoyed educating people on how to deal with discharge planning.
All right, y'all. We'll see you right back here next time on Care Lab. Bye.
Bye, everybody.
Bye.